Good morning, everyone. It's my pleasure to welcome you to Gallie Day and say how happy I am to see all of you here this morning, and thank you for attending. I want to just say a couple of words about William Gallie. Somewhere in here there's a slide with William Gallie, for whom today is named. So Dr. Gallie is a Canadian surgeon who started off with general surgery training and became an orthopedic surgeon, and I think throughout his career did both kinds of procedures. He worked at Toronto General Hospital and Sick Children's Hospital, and focused on both pediatric and adult orthopedic deformities. He developed a lot of innovative procedures and was very interested in new technology and its evaluation, and that was the focus of his career as an investigator. He was the chair of the Department of Surgery here in Toronto from 1929 to 1947. Long period of time, and imprinted this department with what we could call as the forerunner of CBD. So prior to that, there was sort of an apprentice model of surgical training, and he transformed it into an actual formal program with rotations, requirements, and evaluation. So we owe that to him, and it's in his honor that the Gallie program, which all of our trainees are enrolled in, and Gallie Day are named. Next, I wanted to just say thank you to all of the research supervisors who are here. Today celebrates three groups of people: those trainees who are in the Surgical Scientist Training Program, those who are not, but are doing research in some capacity, either as students or fellows or residents outside of the SSTP, under the tutelage of a faculty member, and then all of our research faculty who supervise this kind of research. So all three groups deserve a lot of credit and will be highlighted throughout the day today. I want to thank Michael Failings, our Vice Chair of Research, for being the linchpin that puts this day together, but also, very importantly, Renata Musa, who you probably saw outside, who has taken over from Val Cabral, who is also making a guest appearance today, which is great. So please, if you encounter Val, say hello and express your gratitude for all the years that she put Gallie Day together. And then I want to just thank the members of the research committee. In particular, Andrea McCart, who organized the poster session, Andras Kapus, who's our associate chair of the research committee, And all the other members, Marcelo Seipel, Kristen Davidge, Peter Dirks, Rebecca Gladdy, Lorene Hatcham, Charles Demestral, Malak Elbatarni, Paul Karanicholas, Girish Kulkarni, Renki Lee, and Giuseppe Papia. Giuseppe's down here. Hong Sun and Albert Yi. And joining them this year is Jas Chahal, who's going to be the lead of the Innovation and Entrepreneurship Committee of the Research Committee. So all of them have worked very hard all year and brainstormed and planned, and today will be the ultimate fruit of their labors over this year. So I want to thank all of them very much. And I will now bring Michael Failings up to the podium to introduce the rest of the day. Thanks, Michael.
Thank you, Carol, and welcome. And it's it's wonderful to be getting back to these in-person events. 49th Gallie Day. Wow, what a tradition! So it's my pleasure to introduce Vice Dean Justin Nodwell to bring greetings from the Faculty of Medicine.
Thank you, Michael. Good morning, everyone, and welcome on behalf of the faculty and the dean and myself. I'm at something of a disadvantage in front of a group like this. I'm a basic scientist. My lab, I'm a biochemist. We study antibiotics in my lab. I have my lab meeting in about 20 minutes. But in this position, I've been in this position for about 2 years now, and I've had the great privilege of getting to know the clinical world a lot better than I did previously, and it's been a fascinating journey, I have to say. And so I would like to really commit to supporting this group to whatever extent I can. I'm really interested in forging stronger ties between the basic scientists and the more clinically oriented scientists. It's the success of the clinician scientist model at this university is absolutely outstanding. Michael was just telling me that there's no less than 12 people in neurosurgery, 12 MDs in neurosurgery alone who are getting their PhDs. That speaks volumes. The Department of Surgery and the surgeon scientist is really a jewel in a very crowded crown in this faculty, and I'm really keen to support that going forward. I have no specific examples, but I will say I was intrigued that artificial intelligence is in the title today. The university recently received a very large grant, more than $200 million from the federal government to support artificial intelligence research. The grant was initiated in chemistry, and it has 6 nodes called self-driving labs. I'm not crazy about the title, but in any event, it's going to be a transformative endeavor, and we're currently trying to position those 6 nodes throughout the research community. And so watch for developments there. I'll be very curious to see whether there are opportunities to cross-pollinate between the sort of work that you do and the sort of work that the more fundamental scientists are doing on this campus. So on that note, I will tell you that I am keen to engage with any of you. I'm easy to find on the faculty website. Drop me a line if you want to touch base. Otherwise, I wish you all the best for a wonderful day. Thank you.
Thank you very much, Justin. We appreciate you bringing greetings from the University of Toronto, and your comments around AI are quite apropos, and this is really kind of the theme of this year's Gallie Day, driving the future of surgery, artificial intelligence, and advanced imaging technologies. So a big welcome to Professor Alan Lumsden, and I'll formally introduce Professor Lumsden a little later today. But we had a great evening last night. Got to know each other a little bit, and we're sharing some of the synergies between the University of Toronto and the whole medical community in Houston, particularly at the Methodist unit, which is really quite an iconic institution in medicine in the area of cardiovascular surgery, for sure. So welcome to Toronto, and also a big shout out to to our chair, Carol Swallow, and thank you for all of your great support for the department and for research and innovation. So Carol has already kind of kindly acknowledged the research committee, and in many regards, this is really kind of the engine, the driver, the heart and the soul, if you will, of our research program. I want to also acknowledge a few people. So Anders Kopisch is our Associate Vice Chair and is representing the fundamental basic scientists in our department, which are also a very vital part of what we do. I want to acknowledge Renata Musa, who has taken over from Val Cabral, as Carol has indicated, as our research program coordinator. I wanted to acknowledge, in particular, our two resident representatives, Malik and Lorene, who really, I think, bring a vital component to our research committee. And I also wanted to have a shout out to Andrea McCart, who has always been a very strong supporter of Gallie Day, and thank you again for all of your help and assistance today. So this is a new endeavor. So we are calling this the Innovation and Entrepreneurship Committee. It'll be led by Jazz Chahal, who's just recently joining our research committee. And the idea really here is to help to drive innovation and entrepreneurship. And I think this is consistent with where the University of Toronto is going. I think it's quite appropriate that we're having this year's Gallie Day here at Mars, which I think in many regards is really the heart and center of the biotechnology core in Toronto, which is one of the most rapidly growing biotechnology centers in North America, both in terms of startup companies and jobs and so on. So we're really quite excited about bringing this on board. And the Surgeon Scientist Training Program, in many regards, as Professor Nodwell has indicated, is really kind of the jewel in the crown, if you will, of the Department of Surgery. And so we will be hearing about a lot of that research. This is also, of course, complemented by the students and trainees that are not in the Surgeon Scientist Training Program, who also bring a tremendous value and depth to our department. So this is a list of our Surgeon Scientist trainees, which is, I think, quite impressive. And this is just kind of the breakdown by the divisions in terms of those doing their master's degrees, PhDs, and then also we've recently been encouraging also individuals who had a graduate degree prior to a medical school or had done an MD, PhD to essentially take advantage of an embedded postdoctoral fellowship program in the department. And so we've now kind of formally recognized that as well. And this just kind of gives you the graphic of the continuing trainees and the new entries. And we've typically been hovering kind of around 45 plus or minus over the last a number of years. This just gives you a kind of a breakdown of grant funding, so kind of hovering around $100 million a year in grant funding for the Department of Surgery, which I think is really quite a remarkable achievement, and then also publications. And I think the academic impact of the Department of Surgery at the University of Toronto is quite substantial, and I think is a large part why the University of Toronto Department of Surgery is ranked among the top 3 in the world. So big thanks again to Andrea, to Val Cabral, and to Renata, as well as to our oral presentation chairs, Amin Madani and Chaya Schwartz. And I've also listed all of the faculty who have contributed their time and their effort and their passion, and it's really greatly appreciated, because you're really kind of the heart and soul of what makes this a great department. And just a special thanks again to Renata, who has put in a great deal of effort and care, making today very special. So with those introductory remarks, I would like to call on the first session chair, Dr. Amin Madani, who's an endocrine and acute care surgeon in the Division of General Surgery at University Health Network. And Amin's going to be a busy guy today, because in addition to chairing this morning, he's also going to be giving a talk at our symposium after lunch. So Amin, over to you. Thank you.
Good morning, everyone. My name is Amin Madani, and I have the honor of chairing the first session. Thank you, Dr. Failings. Thank you, Dr. Swallow, and thank you, Dr. Lumsden. Welcome to Toronto. I'd like to ask all the speakers to try to stay on schedule if possible. I'd like to welcome our first speaker. It's Dr. Justin Wang. Dr. Wang is a PGY 4 neurosurgery resident enrolled in the surgeon scientist program at the University of Toronto, and he's doing his PhD in the lab of Dr. Gallie. Title of the talk is Comprehensive Genomic Characterization of CDKN2A Alterations in Meningiomas. Dr. Wang.
Okay, thanks very much, Dr. Madani. Really appreciate it. My name is Justin. I'm one of the PGY4s in neurosurgery, doing my PhD with Dr. Zadeh. It's a great honor to be here at Gallie Day, so thank you for the opportunity. Do I have my slides? Okay, perfect. So I'm going to be talking to you about a bit of our work that we've been doing on meningiomas. So meningiomas are extraaxial tumors that grow outside the brain. Sometimes they look like this, but oftentimes when we see patients, they look more like this. And importantly, meningiomas are the most common brain tumor in adults. And even more importantly, unlike most other CNS tumors, these meningiomas are increasing in incidence with an increasingly aging population. So although these tumors are considered non-malignant, we shouldn't consider them benign. There's a subset of clinically aggressive meningiomas that are very hard to deal with clinically. Up until recently, these tumors were graded almost entirely based on histopathology. So the difference between a grade 1 and 2 meningioma could just be the number of mitotic figures that you count there, which is suboptimal. Fortunately, in 2021, the WHO introduced the first molecular criteria for meningiomas. One of these includes homozygous deletion of CDKN2A as a criteria for WHO grade 3 meningiomas. This was largely based on this study from the DKFZ that showed that tumors that had CDKN2A homozygous deletion did far worse than those without this deletion. So CDKN2A is a tumor suppressor. It encodes for a protein called P16, which then inhibits the interaction between CDK4 or CDK6 with cyclin D, which maintains the retinoblastoma or RB protein in the hypophosphorylated state, and then leads to cell cycle arrest. And it's been implicated in many cancers, and there's been many mechanisms of inactivation, and it's quite cancer specific, so we wanted to investigate this more in meningiomas. The problem is for meningiomas, it's a rare alteration, so less than 5% of all meningiomas have this deletion. So in order to really study this, you need a large molecular cohort. So that's what we assembled. We assembled over 1,500 meningiomas with DNA methylation data, 561 of which had RNA sequencing data, and then 167 had protein data, either bulk proteomics or immunohistochemistry from these cohorts here. First we found there were multiple different patterns of CDKN2A deletion. You could have deletion of just one copy of the gene. You could have deletion of both copies of the gene on chromosome 9p where the gene is located. You could have deletion of the gene with a segment of the 9p arm, both copies, or you can have deletion of the entire 9p arm, either one or both copies. And this is sort of the distribution of the types of deletions, but ultimately we found that it doesn't really matter. If CDKN2A is lost, it doesn't matter what the type of deletion is, what the associated 9p loss is, patients do worse. And CDKN2A deletion as well is, we've confirmed that obviously it's quite rare, but whenever it's found, it's associated with worse outcomes. But interestingly, even if you lose just one copy of the gene as a heterozygous deletion, it leads to equally poor outcomes as if you lose both copies. But what about for the meningiomas that don't have any CDKN2A deletion? So over 90% of the rest of the meningiomas. We found that this group could be dichotomized into two different groups based on their RNA transcription level of the CDKN2A gene, into a low and a high group. And importantly, you can see that the high expressors obviously express CDKN2A at a high level, the low expressors at a lower level. But even the low expression group express it at a higher level than the homozygous deleted tumors, which have essentially a null level of expression. The heterozygous deleted tumors have a more heterogeneous level of expression. And interestingly, you can see that the tumors that have low expression of CDKN2A, that don't have any deletions, actually do the best. And those that have high expression do worse, followed by those that have the deletions. And on a multivariate analysis, both CDKN2A deletion as well as CDKN2A expression were independently prognostic. And this relationship also appeared to hold true within each WHO grade. But what's also interesting is as you go up by WHO grade, this level of CDKN2A RNA expression actually increases, and this was corroborated on a protein level as well. So P16 is the protein product of CDKN2A. But what we know now from our study, as well as works by others, are that molecular groups and methylation groups may predict behavior better than the WHO grade. But even when you put these meningiomas into these different molecular classifications, you can see that as you go up into increasingly more aggressive molecular groups, the CDKN2A expression increases. So because CDKN2A high expressing meningiomas and CDKN2A deleted meningiomas both have poor outcomes despite being mutually exclusive groups, we want to see if there's any pathways that underlie this shared biological aggressiveness. And so we looked at the RNA transcription pathways, and we found that both of these groups were highly enriched for cell cycle pathways at different checkpoints. And our pathway enrichment analysis corroborated this. And I want to sort of draw focus of the CDK pathway, which is an important downstream effector of CDKN2A. So you'll recall this pathway that I put up earlier. CDKN2A normally negatively regulates CDK4 and the interaction between CDK4 and cyclin D. So with higher expression of CDKN2A, you might expect that CDK4 would be decreased. We actually saw the opposite. In every cohort that we looked at, CDK4 RNA expression was increased in the higher CDKN2A expressing meningiomas, and this was corroborated on a protein level as well. So what this suggests is perhaps there's some other process that's increasing CDK4 expression downstream, and this is feeding back to then increase CDKN2A expression in an effort to basically stop this cell proliferation. And this is important because it brings up a potential therapeutic avenue in using CDK4 or 6 inhibitors for meningiomas, which has been suggested. The problem with CDK4 and 6 inhibitors is that it acts basically at the CDK4 and 6 interaction point to stop phosphorylation of RB. But if a tumor doesn't have the retinoblastoma protein, if it's RB deficient, then these tumors are resistant to CDK4 and 6 inhibitors. So in order to see whether our meningiomas were RB deficient, we did a RB Western blot. And we found, interestingly, that if you look at the CDKN2A high group, there was a large proportion of these tumors were actually RB deficient, and you didn't see this in any other group. So these tumors, we suggest, are probably resistant to CDK inhibitors. To test this, we isolated several primary meningioma cell lines from patients that closely resemble their parent tumors based on DNA methylation. We confirmed that they were high CDKN2A expressing and RB deficient on an RNA as well as a protein level. And then we treated them with 2 different CDK4 and 6 inhibitors at escalating doses. And what we found was that these RB deficient CDKN2A high cell lines were resistant to CDK4 and 6 inhibitors, whereas the other cell lines were not. So then how do we, so we basically now have this prognostic biomarker that has potential therapeutic implications. How do we apply that clinically? Because realistically, not every site is going to be able to do RNA sequencing on every meningioma. But fortunately, we showed that CDKN2A expression correlates with P16, which is the gene product, and we have a P16 immunohistochemical stain that's used in head and neck cancers to detect HPV infection. So we wanted to see if this would work in meningioma. So we stained 71 meningiomas with P16 IHC. We got 2 independent neuropathologists to score these based on the degree of positivity, blinded to CDKN2A status. And what we found was that if you look at the top panel there, This stain doesn't really do a very good job of differentiating whether or not you have a CDKN2A deletion, but the tumors that have high expression tended to have a very strong degree of positivity. And if you break it down into tumors that have homozygous deletion versus those that didn't have any deletion, and then by WHO grade, you can maybe appreciate again that it's not the best stain to determine whether or not you have loss of P16 for these tumors, but if you plot the mRNA expression values based on the degree of positivity, you can see that the tumors that were highly positive, or 3+, had a significantly higher degree of RNA expression. So this could be a potential immunohistochemical marker that can be readily translated and used in pathology labs everywhere. So just to wrap up, some of the novel findings that we found were that heterozygous deletion of CDKN2A leads to as poor outcomes as homozygous deletion. Hopefully this will be updated in the new WHO. CDKN2A RNA expression is a marker of clinical aggressiveness for meningiomas, as well as potential therapeutic resistance to CDK inhibitors. And P16 IHC may be a marker of high expression, but obviously needs to be validated in larger cohorts, multiple institutions with matched molecular data. So I have to thank my supervisor, Dr. Gallie for her mentorship, Farshad Nasiri, our senior resident who oversaw much of this work, as well as our bioinformaticians, Vikas Patel and Jeff Liu for helping with some of the analysis, and our funding agencies and the SSTP program. Thank you.
Thank you. This abstract is now open to discussion, and I'd like to call on Dr. Radovanovic if he's available as our first discussant.
Thank you, Justin. Amazing work. Congratulations. I think you have really shown that beyond just the loss of CDK and to a loss of heterozygosity or single deletion or double, the expression of the gene can refine the diagnostic criteria, and you propose then to use P16 immunohistochemistry as a surrogate. Are there assays to measure directly CDK and 2A protein, or with immunohistochemistry that can actually be used directly to answer that question?
Yeah, I think so. There's been several. I mean, I think you can for these tumors, P16 in our study as well as others hasn't been shown to be very reliable for detecting whether or not there's loss or whether or not there's CDKN2A protein. But there are other stains like MTAP, which is a gene basically right next to CDKN2A, and that IHC seems to do a better job of detecting whether or not there's deletion or not. So you could potentially use P16 and MTAP in combination. Use MTAP to see whether or not there's deletion, and then if not, then use P16 to then gauge the level of RNA expression. So then, and those are things that, you don't need methylation, you don't need RNA sequencing to be able to do. So they should be highly translatable.
And do you see such an assay only for refining diagnostic and prognostic survival, or also as a marker for potential response to therapy?
Yeah, that's a good question. So I think it does have potential as a therapeutic marker, because CDK4 and 6 inhibitors are something that's sort of in the pipeline to go into clinical trials for meningiomas. And what we've shown is basically that the CDKN2A high expressing meningiomas will not respond to these. So if you can detect that, then I think you can basically you should theoretically exclude these patients from these trials, because they're likely not going to have a response. And I think that's probably the direction that most of these trials are going towards, are like a molecularly informed trials, as opposed to just based on WHO grade, which for meningiomas is still largely histopathology based.
Thank you.
Thank you.
Then we had another question from Dr. Platti.
I just want to congratulate you on a beautiful body of work. I had two focused questions. The first, we struggle with this in sarcoma, these tumors that are supposed to be benign, but we know they're not. What do you mean by outcome? Because I kept seeing progression-free survival. What's bad outcome in this disease, so we understand?
Yeah, that's a great question. So unlike sarcomas, which obviously are malignant, these are non-malignant tumors. So for outcome here, it's progression-free survival. So overall survival for meningiomas, it generally tends to be much longer, but the problem with these tumors is not that they actually cause mortality. They do, but the problem with these tumors is that they keep coming back. And right now, the only modalities of treatment that we have are surgery and radiotherapy. So invariably, if these tumors keep coming back, we have to end up reoperating on these patients, re-irradiating them, and then even though it may not kill them, it leads to a horrible quality of life and significant morbidity.
And then my second focus question is the computational bias that we have in looking at the gene that we love, right? So what do you think the interrelationship is here between P16 and RB? Have you had the opportunity yet to do a computational analysis to get a sense of what comes first in this chicken and egg story? What's really the driver here? I'm not sure if you have any sort of evolutionary history of early meningiomas versus ones, for example, that recur. Can you see how this evolves over time? Does it become more prevalent in the recurrences? I don't know if you have that data.
Yeah, we're looking at that right now, so we don't have that data hasn't matured, but RB is RB mutations and are very rare in meningiomas. They occur in about less than 1% of meningiomas, but clearly there are some other mechanisms that can inactivate RB. For us here, when we looked at our data, hypermethylation of the promoter wasn't really a contributing factor, but again, there are multiple other things, silencing by microRNA, long non-coding RNAs that could silence RB. So I'm not sure whether or not RB is a late event or not. I think that probably loss of CDKN2A is a late event because again, it's quite rare. And we see sometimes in meningioma cell lines that as you sort of propagate these cell lines, they lose CDKN2A and become immortalized as a result of that.
Out of the interest of time, maybe one more question. If I can ask you to just state your name as well.
Yeah, my name is Marguerite Akins. It's really great talk and great work. I have a question. You mentioned that 2 pathologists evaluated the the immunohistochemistry of the P16. How did they grade the staining?
Yeah, that's a great question. So I didn't have time to sort of delve into it in detail, but basically it was sort of on a percentage of cells that were positive. So 0 was basically no positivity. 1 was 0 to, plus 1 was 0 to 10% positivity. Plus 2 was 11 to 70% positivity, and then 3 plus was 70% more.
So they did that by eye?
Yeah, they did it manually. They didn't do it in an automatic way, yeah.
Yeah, so that would have been my question, considering the theme of the day, why they didn't use the software, which automatically can calculate the percentage of staining.
Yeah, I think that would be great. I mean, I think again, if we were to do a larger study with more samples across multiple institutions, I think the automated way would certainly be the way to go, especially to be more objective about the grading. But
I just want to let you know it's available.
Okay, thank you. We will do it.
Okay.
Thank you. Congratulations on great work. I'm going to ask everybody, please don't be shy. I'm going to ask everybody from the back, please don't be shy. Come on in. There's plenty of seats in the front, in the middle. Yep. Okay, next talk. I'm going to invite our next speaker. Her name is Hyojin Sung. Hyojin is a second-year medical student at the University of Toronto, working in ClinEpi, Quality Improvement and Equity in Healthcare, working in the lab of Dr. James Jung. The title of the talk is The Obesity Paradox Revisited. Is obesity still a protective factor for patients with severe comorbidities or in high-risk operations?
Thank you for the introduction. And my name is Hyojin, and I'm a second-year medical student at the University of Toronto. And I want to thank the organizing committee of Gallie Day for giving me the opportunity to present our work. Oops. All right, I have no disclosures. So with the rise in prevalence of obesity around the world, more than 2 billion people are overweight, with 4 million deaths yearly attributed to obesity. By 2031, 1 in 3 Canadians are projected to be obese. Therefore, healthcare providers in the future will be serving a greater patient population with obesity. Defined as having a body mass index of greater or equal to 30, obesity is associated with a higher risk of comorbidities such as cardiovascular diseases as well as certain types of cancers. Therefore, intuitively, it is commonly and widely presumed that patients with obesity have poor health outcomes or are at a higher risk for surgery. However, studies have shown that when faced with acute illness, such as critical illness or patients that undergo surgery, patients with obesity tend to have better outcomes, or in other words, improved survival. This is known as the obesity paradox. Seen in patients with heart failure, acute lung injury, chronic renal failure, as well as those that undergo critical illness, studies have shown this U or J-shaped relationship between BMI and mortality, showing lower risk for mortality with increasing BMI. So this is counterintuitive to what many surgeons would think of when treating patients with obesity. Patients with obesity tend to have high comorbidities as well as undergo challenges in operations due to their body habitus. However, the obesity paradox states otherwise. Therefore, it's important to adjust for these two factors when exploring the relationship between BMI and surgical outcomes. And currently, it is unknown whether the obesity paradox extends to patients with severe comorbidities or those undergoing high-risk surgery. Therefore, the objective of our study was to explore this relationship, the obesity paradox, using and adjusting for these two factors in a more nuanced way. So to do this, we conducted a retrospective study using the 2016 to 2019 American College of Surgeons National Surgical Quality Improvement Program, which collects multi-institutional data on patient demographic, preoperative factors, as well as 30-day postoperative outcomes. And the database applies the following intrinsic inclusion and exclusion criteria to the cases collected in between 2016 and 2019. The primary outcome of our study was 30-day postoperative mortality, with BMI categories defined by the World Health Organization as our independent variable. The covariables that were adjusted for include patient demographic factors, 19 preoperative characteristics such as the patient's functional status, their comorbidities, etc., as well as 3 intraoperative variables. So in terms of statistical analysis, we conducted multivariable logistic regression analysis as well as restricted cubic spline modeling to examine the effects of BMI on postoperative mortality. So as a result, our total cohort consisted of approximately 4 million patients that were collected in the database, and after excluding those over the age of 80 years old and patients with missing data, the remaining total of approximately 3 million patients were included as our study cohort. So a majority of our cohort were female with a median age of 57 years old. Most of them were Caucasian and underwent elective procedures, with only 7% being emergency cases. Slightly less than half of our cohort were obese with higher comorbidities such as diabetes and hypertension. So taking a look at our overall study cohort, the mortality rate was 0.6%. And we can see that in the plot showing the adjusted odds ratio and 95% confidence intervals for each BMI category compared to the normal weight class, overweight and class 1 to 3 obese category had significantly lower odds for mortality compared to normal weight patients. In the restricted cubic spline plot showing increasing BMI on the x-axis and increasing odds for mortality in the y-axis, we can see this reverse J-shaped relationship with highest and lowest odds for mortality seen in the underweight and obese class 2 category respectively. So overall, the protective effects of obesity was seen in our entire study cohort. Further subgroup analysis was conducted with the cohort stratified by comorbidity load and procedure risk. High comorbidity load was defined as patients with having estimated mortality probabilities in the top 3%, which equate to a mortality risk of greater or equal to 4%. And a modified Charlson Comorbidity Index was also calculated for each patient using the following variables and the corresponding point values assigned to each comorbidity. A high comorbidity load was defined as having a total score of greater or equal to 8. So in the group with top 3% mortality probabilities, the mortality rate was 13.2%. And we can see that the protective effect seen previously in our entire cohort has diminished. Compared to normal weight patients, class 1 and 3 obese categories was no longer associated with lower mortality risk. In the group with a high total MCCI score, we can see that class 1 to 3 obesity was no longer associated with lower mortality risk compared to normal weight patients. And overall, this suggests that the obesity paradox did not extend to those with high comorbidity loads. Next, the group was stratified based on procedure risk. So generally, risk classification of procedures are not as well defined as they can differ in terms of patient and operation-specific factors. Therefore, for our study, high-risk procedures was defined and classified using CPT codes from previous studies that risk stratified based on transfusion risk, mortality risk, as well as by referencing guidelines that were published, as well. Furthermore, the list of procedures were reduced by using clinical judgment from 3 practicing surgeons. So a total of approximately 257,000 patients who underwent high-risk surgery were compiled, and we can see that the majority of the procedures are abdominal surgery, with examples including total colectomy, pancreatectomy, and liver resection. And some other high-risk operations include AAA repair, pulmonary resection, lobectomy, as well as major spine reconstructive procedures. So in patients who underwent high-risk procedures, we can see that the underweight patients were at significantly increased risk for mortality, whereas overweight patients were at significantly lower odds for mortality compared to normal weight patients. However, there was no significant difference in postoperative mortality between patients in the obese and normal BMI class, overall suggesting that the obesity paradox didn't seem like it extended to patients undergoing high-risk surgery. So some of the limitations of our study include unmeasured or residual confounding factors, as well such as patient nutritional status, as well as surgeon and hospital-specific variables not included in the NESQIP database. As well, since the database only collects outcomes data during the first 30 days of the postoperative period, we could not explore the relationship between BMI and long-term outcomes. So overall, our study results suggest that for the vast majority of adult surgical patients undergoing major surgery, obesity was associated with a lower risk for mortality. However, the obesity paradox did not extend to those undergoing high-risk surgery or those with severe comorbidity lows. That concludes the presentation, and thank you for your attention. And lastly, I'd like to thank my mentor, Dr. Zhang, as well as the co-authors for making this possible.
Outstanding presentation. This abstract is now open to discussion. I'd like to call on Dr. Sam Park as the discussant to comment.
Great work. Looks like you put a lot of time and work into it. Just a few quick questions. I know you mentioned at the end the limitations was the 30-day window just because of the data, but did you also look at things like reoperation rates or infection or complications? Because in some surgical subspecialties, you do see obesity can be related to that.
Oh, yeah, for sure. So for our major study outcome, it was 30-day postoperative mortality, so we did not look at other things like reoperation or complications. But there has been previous studies that's been done in terms of those 2 factors, and I think that's another way that we can take this project, analyzing those 2 outcomes.
Okay, perfect. The other thing, when I looked at the abstract, there was one part where you said the operative time decreased with increased BMI. I know that could just be a statistical finding just in the database, but do you have an idea of why that might be the case?
Oh, so in terms of obese patients undergoing operation time, that was lower compared to other patients?
Yes.
I think it could be possibly due to the fact that patients with obesity we all know that they're presumed to be higher risk, so they may undergo more intense preoperative assessment, or in terms of the surgical procedure more planning that way, which might affect surgical operation time, but definitely it was a surprise to me when I was going over the data to see that.
That's fair. Last thing was just, as you mentioned, with other studies showing the reoperation rates and complications such as infections. Based on that data and the research you've done, like what would you take out of this in terms of what do you does it change your practice? Do you tell patients differently? Because a lot of the patients in your cohort are undergoing elective surgery, right?
Yeah, for sure. So I think, as I mentioned, obesity is presumed to increase risk of mortality and like complications for sure. And I think the results of our study suggest that this was not the case, as we saw in the high risk and high comorbidity load patients. And obesity was not an independent risk factor for those two patients. And I think in terms of clinical implications, it's important to risk stratify rather whether the patient is obese or not, depending on the type of surgery and the comorbidities that they have. So those are some of the conclusions that I had in terms of clinical implications.
Thanks.
We have one more question from the floor.
Sure. Thank you so much. That was a lot of work. I have two questions for you. You talked about nutritional status and how you did not account for that. If you were to account for nutritional status, how would you do that? What would be the factors that you would look for? And my second question is, what is your working hypothesis for why obesity is protective?
Okay. So in terms of nutritional status, we did take a look at two variables that could serve as surrogates to determine the nutrition state for our patient. So one of them was prealbumin levels, and then the other one was greater than 10% weight loss in the last 6 months. And when we were looking at those two variables, over half of our patient cohort did not report preoperative albumin levels. So that was one thing that we did not include in our covariables, but we did adjust for greater than 10% weight loss as an indicator of nutritional status and possibly malnutrition. And as well as in terms of the working hypothesis in terms of why the obesity paradox or why obesity could be a protective factor is, number one, there could be a greater metabolic reserve for patients with obesity in that the increased fat reserves can help them be more resistant to the stressors of critical illness and prevent them, or I guess prevent them from going towards like catabolic progression. As well, there is also the endotoxin lipoprotein hypothesis, where lipoproteins produced in adipocytes, they act as scavengers for endotoxins, which attenuate the cytokine production. As well, lastly, there could be some kind of performance bias and measurement bias in that there is that presumed risk with patients with obesity are at higher risk, so they might undergo more aggressive treatment or early preventative measures, as well as BMI is a variable where it's the risk between it's the ratio between weight and height, and it doesn't capture the lean body mass of a patient or the distribution of fat, as well distinguish between adipose tissue and muscle mass. So those are all like lean peripheral distribution of fat as compared to central adiposity and increased lean body mass are protective factors. So those are some of the things that could possibly explain the obesity paradox, although it is multifactorial and there's a lot of research and questioning regarding the pathophysiological process of the obesity paradox.
Okay, excellent. Thank you.
Thank you.
Outstanding work. Congratulations.
Thank you.
We'll now call upon our next speaker, Ms. Julia Nomikos. Julia is a master's student at the Institute of Medical Science at the University of Toronto, and she works in Dr. Rebecca Gladdy's laboratory. The title of the talk is The Impact of Magnetic Resonance Guided High-Intensity Focused Ultrasound Generated Hyperthermia and Chemotherapy on the Immune Profile of Murine Model of Rhabdomyosarcoma. Take it away.
Thank you, Dr. Madani, and thank you to the organizing committee for allowing me to present our research.
So our research focuses on rhabdomyosarcoma, which is the most common pediatric soft tissue sarcoma, and it generally originates from myoblast skeletal muscle progenitor cells. Now, the most common subtype of rhabdomyosarcoma, or RMS, is embryonal rhabdomyosarcoma, or ERMS, and treatment includes chemotherapy, radiation, and surgery. In terms of first-line chemotherapy standard of care, it's VAC, which stands for vincristine, actinomycin D, and cyclophosphamide. Patients then go on to have a 5-year survival rate of approximately 70 to 80%. But in cases of relapsed or recurrent disease, second-line chemotherapeutic agents such as doxorubicin, etoposide, and ifosfamide have to be turned to. And unfortunately, these patients have a very poor 5-year survival rate of about 30%. Something else to really note about RMS treatment in general is that it is quite systemically toxic. For example, doxorubicin is known to be quite cardiotoxic. And so this really demonstrates a need for novel therapies that are not only more effective, but are less toxic. So one way to reduce systemic toxicity while increasing on-target effects in localized disease specifically is to locally deliver a drug to tumor. And one of the ways we do this is by combining two methods. So the first is magnetic resonance guided high-intensity focused ultrasound, or MRG HIFU, and we do this in collaboration with the Drake Lab at the Hospital for Sick Children. MRG HIFU, in short, uses MRI images to guide focused ultrasound in order to heat regions of tissue. So in our case, we use it to locally heat tumors, and this heat, or hyperthermia, I will also be referring to as HT throughout this presentation. So we combine MRG HIFU with thermosensitive liposomal doxorubicin, or TLD. TLD is simply doxorubicin encased in a liposome that is released at an elevated temperature of about 40 degrees. So you can see how locally heating the tumor combined with a drug that is only released at an elevated temperature could be a really great treatment option. And indeed, the Gallie lab has previously shown that HT plus TLD treatment is associated with improved survival in a syngeneic ERMS mouse model, as denoted by the navy blue line you see here. This treatment group not only had improved survival, but they had the slowest tumor growth, and they also had less doxorubicin accumulation in off-target sites such as the heart and liver. But something else we know from the literature is that hyperthermia can stimulate the immune response through the release of heat shock proteins and immunogenic targets from cancer cells. In terms of what we know about immunotherapy treatment success in soft tissue sarcomas, it doesn't seem to be as robust as in other types of tumors, and immune profiling data specific to rhabdomyosarcoma is quite sparse in the literature. But if hyperthermia from this very promising therapy of HT plus TLD treatment could be stimulating the immune system, then immunotherapy in combination with HT plus TLD treatment might be even more effective. And so this led us to our research objectives, which were to characterize the immune profile of a murine model of ERMS by investigating the presence and location of immune cells within tumors, to determine what effect different types of chemotherapy and hyperthermia are actually having on immune infiltrate, and to actually understand what this immune response is looking like over time. We hypothesized to see an increased immune response in hyperthermia-treated groups when compared to their respective normothermia or NT groups. So our experimental protocol was as follows. We injected a murine ERMS cell line into the right hind limb skeletal muscle of mice and allowed time for tumors to form. Once the tumors had formed, we divided the mice into two groups, an HT treatment group, which underwent MRG HIFU to locally heat the tumors, and an NT group, which did not receive heat treatment at all. Within these two groups, we also treated with drugs for a total of 8 experimental groups. So within the HT and NT groups, mice were either treated with no drug or control, free doxorubicin, or FD, vincristine, or vinc, and TLD. We wanted to examine 2 time points after treatment, 24 hours and 1 week, or 168 hours, to look at the innate and adaptive immune response, respectively. And once we did so and resected those tumors, we performed immunohistochemistry, and in a subset of tumors, we also conducted imaging mass cytometry, which I'll get into a little bit later in the presentation. So beginning with the immunohistochemistry results, we looked at 3 different markers. The first was CD11b, which is a marker of monocytes, macrophages, neutrophils, NK cells, and granulocytes, which will be outlined in red throughout the presentation. We also looked at CD3, which is a marker of T lymphocytes, outlined in green, and B220, which is a marker of B lymphocytes, which will be outlined in blue. Immediately we saw that of the 3 markers, CD11b positive cells were the most abundant, followed by CD3 positive cells, and very few B220 positive cells, as you can see in these representative images, with blue indicating nuclei and brown the stain of interest. Now, before analyzing the effect hyperthermia was having on immune cell infiltrate, we wanted to understand what drug alone was doing to the tumors. So in this slide, you are seeing data from tumors that have not been heat treated at all. This is just the drugs by themselves. And we saw 3 areas of significance when we looked at this. And interestingly, it was between the same 2 groups each time. In each of these graphs, you can see that TLD treated tumors have a lower immune cell infiltrate than the untreated tumors. And we see this in CD11b positive cells at 24 hours and CD3 positive cells at both time points. Now, this is intriguing because we were not expecting to see this result, and the mechanism behind this has yet to be elucidated, but it's definitely something we will be looking forward, further into because clearly there seems to be a pattern. Now, to determine what effect hyperthermia was actually having on the tumors, we compared hyperthermia-treated tumors, outlined here in white, with normothermia tumors outlined in the dark bars. And we saw 2 areas of significance when we were looking at this. The first was that hyperthermia increases B cell infiltrate in untreated tumors at 168 hours post-treatment. And this is quite interesting because STS studies have shown that B cell infiltrate can correlate with improved prognosis. But furthermore, when we look at this, we see that drug-treated tumors do not seem to have the same trend, and this indicates drugs could be having some sort of effect here. The next area of instance showed us that hyperthermia increases CD11b positive cells in TLD-treated tumors at 24 hours post-treatment. Once again, this trend is specific to this TLD group as opposed to the other groups. What's likely happening here is from the previous slides, we know that TLD seems to be lowering immune cell infiltrate, but that hyperthermia now seems to be counteracting this. But something else to really note with CD11b is that it's a marker of multiple myeloid immune cells. As a result, what individual immune cell populations are doing here in this graph might be lost. And that is why we have been conducting imaging mass cytometry. So imaging mass cytometry, or IMC, is an advanced technique. It allows us to analyze up to 40 different markers on the same section of tissue. So what you're looking at here in this figure is the periphery of an untreated tumor. All of these images are of the same section of the tumor, but each one is looking at a different marker, and the highest density stains have been pseudocolored. From this data, we can see the most abundant immune-related stains are pointing toward a macrophage-dominated tumor microenvironment, while the least abundant stains are telling us there are sparse B cells, which again we did see in the IHC data, but also very few granulocytes. Furthermore, the majority of T cells seem to be CD4 positive helper T cells as opposed to cytotoxic or T regulatory cells. Now, we use this IMC data to compare images from 3 different tumors: an untreated tumor, an HT 24-hour tumor, and an HT 168-hour tumor. In these images, CD64, which is a marker of macrophages, is outlined in red, and MHC2 is in blue, which is a marker of antigen-presenting cells. You can see that in the HT 24-hour tumor, there are more macrophages compared to either of the other 2 tumors in the periphery. And when you look at the center of this same tumor, you can see clustering of MHC2, which is not observed in any of the other 2 tumors either. And this is just providing further evidence for the fact that hyperthermia is stimulating an immune response at this time point. So in conclusion, the immune microenvironment of this RMS mouse model is macrophage dominated, B cell deficient, and cytotoxic and regulatory T cell deficient. And hyperthermia may increase immune infiltrate, particularly with respect to macrophages at 24 hours and B cells at 168 hours. And this project, and as well, TLD might actually be suppressing CD11b and CD3 positive immune cell infiltrate, and this is something we have to look into further. In terms of the significance of this project, understanding the location and presence of immune cell populations in tumors over time will help us identify future immunotherapeutic targets for RMS and will help us understand whether we can harness HT-related immune stimulation from an already promising therapy to treat rhabdomyosarcoma more effectively and in a less toxic manner. I'd like to thank my supervisor, Dr. Gallie, the entire Gallie lab, my MSc committee, the Drake lab, UHN, all our other collaborators, and of course our funding sources. None of this would have been possible without them. So I'd love to take any questions.
Thank you. What an outstanding body of work. This abstract is now open for discussion. I'd like to call on Dr. Andrea McCart as our discussant.
Thank you. That was a great work, and I think everyone realizes how important it is with the more development of more immunotherapies for cancer, the ability to know what the immune profile is of tumors, but also how to turn cold tumors into hot tumors, which I think is ideally where this is going. I have a couple questions about the timing. The first question is about the timing that you looked at. Like, I know you describe looking for innate versus adaptive immunity, but did you do other experiments to see if you're picking up the actual maximum sort of height of the immune profile that you're looking at?
So initially when we started this, we had multiple other time points, not just 24 hours and 168 hours post-treatment, but we quickly realized that immune cell data is quite variable within tumors. And therefore, in order to try and achieve any sort of significance and understand what was going on, we really needed to narrow ourselves down. So we chose those 2 time points because they seemed to be, a day after and a week after, pretty classic, innate and adaptive. But I do agree with you that it would have been ideal to do a bunch of different time points. At the same time, we want to make sure we're achieving significance and having enough power, so that was kind of the trade-off.
So another timing related question, and I don't know if you talked about it here, but in your abstract about the timing of everything related to the heat. So I noticed the drugs are actually administered quite early in the process of the heat. And then later on you look at the immune profiles. But I'm just wondering, if you're trying to make tumors hot or cold, if the drug should be held off longer, like maybe there would be a better response to the drugs if the tumors are already hot.
That's a really good point. I think that for the TLD specifically, it definitely made sense to administer both at the same time, because if the TLD is not being heated, it's not going to release the doxorubicin. But in terms of the other groups, like doxorubicin and vincristine, I can understand what you mean, and that's definitely something we could look into going forward.
Do you know if, did the heat itself have an effect on tumor responses without drug?
So unfortunately, we're not exactly able to evaluate that because I have to necropsy the mouse either 1 day or 1 week post-treatment in order to get the tumor. Measurement, the only kind of marker we could use potentially is the week post-treatment and measurement, but measuring the tumor before and after is quite difficult and a little bit variable, and we don't have too much of the data on that, so no, we were not able to look at that.
And my last question is just about, I know it's preliminary, but the data that you showed with the imaging mass cytometry, what do you think the importance will be of whether the immune cells are found in the periphery or in the center of the tumor?
That's a good question. We definitely saw that just generally and in general, and this is seen in the literature as well, that immune cells, there's a higher density in the periphery of the tumor. I'm not exactly sure the prognostic implications of this or how this would translate to clinic exactly. That's definitely something I'd have to dive more into the literature for.
Okay, thank you.
We'll get some comments from our visiting professor, Dr. Lumsden.
Alan Lumsden, congratulations. All these presentations have just been incredibly stimulating. Several years ago, we worked on a construct of furoheme nanoparticle hooked up to TPA, the clot-busting drug, and used MR to heat up the nanoparticle, which then accelerated the dissolution of thrombus. It worked great in the lab. It was a little more challenging to figure out how we were going to deliver this clinically. And so my question is, you're using 2 different energies. Number 1, why a lipoprotein nanoparticle? Can you use other constructs? Number 2, how hot is hot, and how much can you focus that when you scale this up and try to apply it clinically?
So I'll answer the second part first. We are not ablating these tumors. We are heating to about 40 degrees. Hyperthermia in cancer is a practice that has been looked into, usually in terms of ablation, though. This is heating to 40 degrees. We're not destroying the tissue. We're simply trying to make it hot enough so it hits the sweet spot of when these liposomes will release the drug. In terms of why liposomes, there are a lot of different treatment modalities out there, such as nanoparticles, and I think that's something that could be looked into moving forward. I think liposomes was just a place for us to start, and we had access to this drug.
Thank you.
Thank you. Outstanding work. I will now call upon our next speaker, Dr. Dave Melia. Dave is a fourth-year general surgery resident in the SSTP program, working in Dr. McCart's laboratory. The title of his talk is In Vivo Drug Screening of Tumor, Immune, and Vascular Response Within the Tumor Microenvironment. Go ahead.
Morning, Dr. Madani. Thanks for the introduction, and good morning, everyone. Thanks to the organizing committee also for inviting us to discuss our research this morning. So virotherapy, or using tumor-directed viruses in cancer treatment, as well as using molecular mimics of viral infection, can exert changes within the tumor microenvironment to components like immune cells, blood vessels. And so these agents work above and beyond direct tumor cell killing through related mechanisms, potentially including the stimulation of anti-tumor immune responses, antivascular effects, and also potential synergism with other more traditional chemotherapeutic agents. And so when developing new cancer treatment strategies with these agents, using experimental approaches that simulate intact, biologically relevant tumor environment is important. So our approach here was to use a zebrafish model of colorectal cancer as an in vivo drug screening platform. So zebrafish are a freshwater fish species very amenable to use in the lab. Their embryos, shown here in the panels on the right, are millimeters in size and transparent. And so under the microscope, small amounts of colorectal cancer cells can be implanted into the embryos. And these develop into tumors with blood vessel development and tumor or immune cell infiltration. And because these embryos are transparent, using fluorescently labeled tumor cells, as well as transgenic zebrafish strains with reporter cell lines, these structures can be visualized using confocal fluorescent microscopy. And so in this way, the tumor microenvironment can be assessed when screening different treatments for things like tumor progression, angiogenesis, anti-tumor and antivascular responses, and also infiltration of these tumors by innate immune cells like macrophages and neutrophils. And so in order to evaluate how antiviral responses within the tumor environment may combine with chemotherapy administration to augment anti-tumor response, we've used the viral surrogate poly-IC. So poly-IC is a synthetic double-stranded RNA analog and toll-like receptor agonist. And so primarily through interactions with toll-like receptor 3, poly-IC stimulates downstream interferon and antiviral response pathways. And so we use the zebrafish model to screen a panel of 30 FDA-approved chemotherapeutics alone and in combination with poly-IC. So this is our screening protocol here. So on day 0, transgenic zebrafish strains are crossed and embryos are collected. And then on day 2, colorectal cancer cells are implanted into these embryos. And then on day 3, after 24 hours to allow for tumor establishment, baseline confocal fluorescent microscopy is carried out. And then the embryos are transferred to 96-well plates where they're treated with each drug through immersion, plus or minus IV poly-IC. And then after 72 hours of treatment, the fluorescent microscopy is repeated to evaluate for treatment response in the tumor environment. And so this is a waterfall plot summarizing our data for anti-tumor effect in the model, which we measured by estimating tumor volume pre and post-treatment. And so this is shown here as a % change in tumor size, with the 0 point on the y-axis demonstrating no change in tumor size after 72 hours of treatment. Positive values an increase in tumor size, and negative values a decrease. So each one of these bars is a different treatment group, with a control group vehicle alone listed here, and a poly-IC group alone here. And so we chose to use the RECIST criteria of a reduction of 30% in tumor volume to define partial response. And by this criteria, 9 out of the 60 treatment groups achieved partial response in the screen. So this is a list of all 60 treatment groups ordered from those associated with progressive disease down to our subset that had a partial response. And what you can see here is in this subset, the majority of these were combination therapies that included poly-IC. And then this is an example of how we use the screen to evaluate other components of the tumor environment. So this is a summary of our results for macrophage response. And so this is measured as a % change in macrophage density in these tumors from pre and post-treatment time points. And so positive values here are an increase in macrophage presence within these tumors after treatment, and negative values are a decrease. And so for many of these treatment groups, we actually found that macrophage numbers decreased after treatment, and examples of this are shown in these representative fluorescence images in the top panels on the left. But then for a subset of groups, we saw a large increase in macrophage infiltration into these tumors, and again with example fluorescence images there. We also, the data aren't shown here, but we also conducted this analysis for neutrophils as well. We looked at antivascular effect in our screen. So we measured vascularity as a ratio of vascular volume to overall tumor volume. And this is shown here again as % change in vascularity from pre to post treatment. And so as you can see, compared to the control group here of vehicle alone, all treatment groups showed sort of a wide range of antivascular effects in the screen. So we aggregated all the results from our screen in terms of tumor response, macrophage and neutrophil and vascular response to select a subset of candidate treatments for further in-depth analysis using more established modeling approaches. And so of these 5, the gefitinib and imiquimod plus poly-IC groups were associated with partial tumor response, large increases in macrophage and neutrophil, as well as large antivascular responses. Osimertinib plus poly-IC, similar results, but without the large antivascular response. And then for the doxorubicin and erlotinib plus poly-IC groups, the partial response in tumors was associated with either a large increase in macrophages or neutrophils, but not both. And then finally, we compared our in vivo results from the zebrafish model to in vitro results obtained using an MTS assay, which evaluated anti-tumor response based on reduction in viability of colorectal cancer cells in culture. And so what this graph is showing is the change in anti-tumor effect for these drugs when poly-IC is added, whether measured through the MTS assay in green or the zebrafish screen in gray. So again, positive results here are an increase in anti-tumor effect when poly-IC was added to these drugs, and negative results or negative values of decrease. So for most of these drugs, whether measured through the MTS assay or the zebrafish screen, poly-IC was associated with an increase in anti-tumor effect. But for the zebrafish screen, the magnitude of this increase was larger for most of these drugs. So if we look at compound 15 in particular, imiquimod, adding poly-IC to imiquimod measured through the MTS assay increased anti-tumor effect by 3.5% compared to 37.6% in the zebrafish model. So this could support the concept that using a screening approach with an intact tumor microenvironment may be capturing anti-tumor mechanisms that are missed in the in vitro assay. So to summarize, we used a zebrafish model as an in vivo screening platform and tested a variety of combination treatments in colorectal tumors. The viral surrogate poly-IC was associated with an anti-tumor effect in our screen in and of itself, and also associated with an increase in anti-tumor effect when combined with many of the drugs that we tested. We saw varied immune and vascular responses across treatment groups, which could be detected by our screen and could be used to select candidate treatments for further evaluation. And indeed, we selected 5 candidate treatments for further testing. And then finally, comparing our in vivo and in vitro data supports the concept that using this type of screening may be capturing anti-tumor effects above and beyond just direct tumor cell killing. So with that, I'll end and answer any questions. Thanks a lot.
That was amazing. Thank you. This abstract is now open for discussion. I'd like to call upon our discussant, Dr. Rebecca Gallie, to comment. And while she's coming up, there's people who've just come late. Please don't hesitate. There's plenty of chairs in the front. Go ahead.
For positive seating. Okay. David, congratulations, because that's actually a technically very challenging functional genomics assay to set up.
Thanks a lot.
So let's talk about the model first, and then I just want to talk in my second set of questions about how you translate this back to cancer patients. So you focused, I think you said, on one cell line in particular. Was there something special about that colorectal cell line? What are your next steps here? Do you think you need to test in this better, potentially model system than the in vitro bench work? Would you look at other cell lines? Do you have colorectal PDXs, for example?
Right. I mean, it's a really good point. So we used an MC38 cell line. So it's sort of an aggressive and high mutation burden cell line. So I think that certainly would impact these results. For instance, how the cells respond to immune therapy or immune-based changes in the tumor environment, for sure. It's obviously a murine or mouse colon cancer cell line, so that impacts things. Part of that is it's easily translatable to what our next step would be, which would be testing the cell line in a mouse model. But certainly using human cell lines and different types of mouse cell lines that have different sort of immune properties or mutational burdens would definitely be an important next step. We had been working with a CT26 line, which is a bit less aggressive than the MC38 with a bit of a lower mutational burden. So that would sort of be one next step to consider. And then the human HT29 cell line. So point well taken. And I think part of it is just the sort of time involved in running the screen that it wouldn't have been feasible to do multiple cell lines.
Yeah, but now that it's working, there's a lot of opportunities there. And then I just want to get your thoughts on combinations to think of, because it's so tricky, right? So what do you know about potential toxicities and synergies, and how did you select the drugs of interest that you've highlighted? Some of them I've never even heard of before. So just help us think through which ones could actually go back to colorectal patients. Thanks.
Yeah, thanks a lot, Dr. Gallie. So I think we tried to select the drugs we tested to represent all the major mechanisms of action of the panel of drugs that we had, but also to make it feasible from a time perspective. Cytotoxic drugs, targeted therapies like EGFR. A lot of the 5 out of the 5 that we selected, 3 of them were EGFR inhibitors, so those were sort of well represented. I think we've shown previously that oncolytic virus treatment and also treatment with poly-IC or viral mimics sort of has important interactions with different types of these systemic treatments. So for instance, with topoisomerase inhibitors, we've shown previously that the viral infection in the tumor environment can affect cell cycle dynamics, which influences the ability of these cytotoxic agents to be effective. And I think one of the important things about the combination treatment is that, as you mentioned with cytotoxicity, we could potentially be reducing the doses of the cytotoxic agents to reduce side effects.
Go ahead.
Hi, I'm Andras Kapush. Very elegant work.
Thank you.
I would like to ask you about the mechanism of action a little bit. So do you think that the poly-IC treatment primarily acts through actually inducing interferon release? And if so, is it from the tumor per se in an autocrine effect, or more from immune cells, or perhaps both?
Yeah, thanks a lot for the question. So I think, poly-IC has been shown to have direct impacts on tumor cells. So through TLR-related mechanisms, it can stimulate apoptosis. So I think, in the MTS assay, we were still seeing anti-tumor effect of poly-IC, and I think so that's a big part of it. This can be related to the reasons why poly-IC has some synergism with other cytotoxic chemotherapies as well, which through P53 mediated mechanism can increase TLR expression on these cells. So I think a lot of it is poly-IC's interaction with tumor cells themselves. And in terms of the immune signaling molecules, there's quite a lot of conservation between zebrafish and human immune systems. So I think, the poly-IC is stimulating in the zebrafish model tumors to release cytokines that are attracting macrophages and potentially polarizing them to a more anti-tumor phenotype. So,
thank you. Amazing work. Thank you.
Thanks a lot.
I will now call upon our next speaker, Jen Dorsey. Jen is a PhD student in the Institute of Medical Sciences at the University of Toronto, and she's conducting her graduate studies in the laboratory of Dr. Rebecca Gallie. The title of the talk is Characterizing Hypoxia-Associated Genetic Features in Extremity Soft Tissue Sarcoma. Go ahead.
Thank you, Dr. Madani, for that introduction, and I would also like to thank the organizing committee for allowing me to present our research today. Soft tissue sarcomas are a diverse group of mesenchymal tumors with over 100 histologically distinct types. Two of the most common types found in the extremities of adults are undifferentiated pleomorphic sarcoma, UPS, and myxofibrosarcoma, MFS. Current treatment for extremity soft tissue sarcoma includes surgery and radiation. And despite high local control rates, the distant metastatic rate is still about 20 to 50%. Thus, there is a need to better understand factors that are associated with aggressive disease to eventually be able to improve outcomes for these patients. One such factor is hypoxia. Hypoxia is correlated with treatment resistance. It can also impact a lot, if not all, of the hallmarks of cancer, such as metabolic reprogramming, inducing angiogenesis, and activating invasion and metastasis. Furthermore, in clinical specimens or clinical cases, tumor hypoxia has been correlated to worse survival in patients with extremity soft tissue sarcoma. This demonstrates that hypoxia is likely a negative prognostic factor, and thus we wanted to determine how we could actually evaluate it in clinical specimens. Immunohistochemistry can be used to detect single proteins that are activated by hypoxia, such as HIF1 alpha and CA9. However, these endogenous markers can be altered by oxygen exposure, and they can also be activated by non-hypoxia-related factors. To combat this, we could use an exogenous tracer of hypoxia, such as pymoditazole, which patients ingest prior to surgery or biopsy. Regardless, though, immunohistochemistry relies on sampling specific tumor regions. To evaluate the total hypoxic volume, we could use functional imaging, such as PET MRI, in combination with a radiotracer of hypoxia, such as FASA. In one clinical trial that did this, they found that 13 out of 23 tumors were actually hypoxic. However, this group did not correlate hypoxia to confirm the molecular mechanisms driving aggressive biology. There have been hypoxia-related expression signatures described in soft tissue sarcoma. However, these studies have not actually separated hypoxic and normoxic cells to really understand the differences between these two populations. In other types of cancers, both in clinical specimens and in vitro work, methylation has been altered by hypoxia. Hypomethylation of gene promoters associated with migration have been documented, as well as hypermethylation of tumor suppressor genes, and also overall global methylation changes, at least in vitro. Due to the limited characterization of hypoxia in clinical soft tissue sarcoma specimens and the molecular mechanisms underlying hypoxia tumor-driven progression being poorly understood, we wanted to characterize hypoxia in extremity soft tissue sarcoma and also relate this to both survival and epigenetic alterations. We hypothesized that hypoxic sarcomas would actually have worse outcomes due to aggressive biology that renders them more likely to recur. This feasibility study had two main aims. One, to determine if hypoxia, as evaluated by FASA PET MRI, was correlated to worse outcomes in patients with extremity soft tissue sarcoma, and two, to analyze the methylation profile of hypoxic and normoxic cells from the same patient tumor. Patients included into this study were enrolled into a clinical trial run by Dr. David Schultz, a radiation oncologist at the Princess Margaret Cancer Center. To limit confounding variabilities due to large differences in biology between STS types, we primarily enrolled patients with MFS and UPS. However, patients with other histologies were also enrolled, particularly when the final pathology differed from the initial biopsy. Patients in Arm A underwent two FASA PET MRI scans, one before and one after radiation, followed by surgery. Patients in Arm B underwent an optional FASA-PET MRI scan followed by surgery, at which point they also ingested pymenidazole, which is that exogenous tracer of hypoxia. And then correlative studies was primarily focused on tissue from patients in this arm. In total, 25 patients have been enrolled in this study since its inception, and here are the clinical characteristics. Majority of the patients either had UPS or MFS, and 20 out of the 25 patients did have a baseline FASA-PET MRI scan. Tumors of patients that did have this baseline scan were classified as normoxic or hypoxic based on the FASA avidness of their tumors. As you can see in the top panel, this tumor is quite FASA avid, indicated by the bright pixels, indicating FASA uptake, and the normoxic tumor is shown on the bottom. And this was also determined based on how much uptake was in the normal muscle. And the radiologists involved in this project do believe that we are detecting hypoxia. So 13 out of the 19 patients that we were actually able to evaluate were classified as hypoxic, and we correlated this to disease-free survival, which is shown in A, and possibly also overall survival shown in B, although at this point it's not statistically significant. Knowing that there's a worse overall survival for patients with hypoxic tumors, we next wanted to investigate the molecular mechanisms. Our plan was to sort hypoxic and normoxic tumor cells based on pymenidazole status. We first wanted to validate pymenidazole in soft tissue sarcoma cells, and we did focus on tissue from patients in Arm B, as those that were in Arm A had very low tissue viability. Pymenidazole stained in a cord-like pattern, as has been previously reported in other types of cancer, and in some cases this was also adjacent to necrotic regions. However, it did also stain more diffusely or in small patches, as is seen in these images. We also investigated the percent of pymenidazole positive cells, and we saw that there was variability both intrapatient, as we did sample multiple tumor regions, and interpatient. This does highlight that it's important to sample multiple tumor regions if using immunohistochemistry to actually determine how hypoxic a tumor is. We also wanted to confirm that pymenidazole was actually binding to hypoxic regions of soft tissue sarcoma, and as such, we detected endogenous markers CA9 and HIF1 alpha. Using immunofluorescence, we were able to determine that there is co-localization of all three of these markers. As such, we concluded that pymenidazole could be used as a marker of hypoxia to sort soft tissue sarcoma cells. In order to evaluate the molecular changes between hypoxic and normoxic cells, we first dissociated tissue and then sorted them with flow cytometry based on pymenidazole status into pymenidazole positive, which were the hypoxic cells, and pymenidazole negative, which were the normoxic cells. Additionally, we used a UPS cell line as a control, which we had incubated in either a hypoxic or normoxic incubator for 72 hours and added pymenidazole to the media. As seen in A is the cell line, and there is a large difference in uptake in pymenidazole, which is on the y-axis. So there's a lot more uptake in the hypoxic cells, which are on the left. However, when we looked at the patient samples, which an example is shown in B, we only saw one population of cells, indicating that there may be a spectrum of uptake of pymenidazole, and thus also a spectrum of hypoxia occurring. Thus far, we have sorted cells from 6 patient tumors. However, only 4 actually had enough DNA extracted to be able to proceed with a methylation analysis. We performed the Illumina EPIC array on the patient samples, but also decided to include UPS and MFS cell lines that were actually derived in the Gallie lab to be able to explore the associated changes from hypoxia in a more controlled laboratory setting. As such, we incubated these cell lines in either a hypoxic or normoxic incubator for 72 hours. Dr. Joanna Prisbel then performed both an unsupervised analysis, which is shown in this heat map, and a supervised analysis on all the patient samples as well as the cell lines. However, we did not see any methylation changes due to hypoxia. In fact, the biggest difference between methylation was just between the samples. To confirm that our cell lines were actually responding to 0.2% oxygen at 72 hours, we quantified the expression of CA9, in which we saw there was elevation in all of the hypoxic cell lines compared to the normoxic cell lines. Thus, we concluded that we are probably working with hypoxic cells, but that methylation is just not altered. To summarize this project, we did see that with this clinical trial, we could detect hypoxia with FASA-PET MRI, and that it's also correlated to a worse outcome in patients with soft tissue sarcoma, at least in the extremities. In the future, this prognostic variable could be either used to personalize tumor management or stratify patients into clinical trials. Although we did not see methylation changes due to hypoxia, further characterization of the molecular mechanisms that are actually driving hypoxic tumors, such as maybe those identified by RNA sequencing, could be used to develop or improve targeted agents. I would like to first and foremost thank Dr. David Schultz, who is the principal investigator of this study, as well as my supervisor, Dr. Rebecca Gallie. I would like to thank all of our collaborators who have contributed to analysis in this project, as well as the surgeons who have provided specimens. And I would like to thank my committee for their ideas, as well as various funding agencies for their support. And finally, to the sarcoma patients who participated in this trial. Thank you.
Incredible work. This abstract is now open for discussion, and I will call upon Dr. Kim Soy to comment as a discussant.
This is really great work, Jen. Congratulations. I guess I have two methodology questions and just one analysis question. I'm just curious first, how was the FASA analysis done? I know you collaborated with a radiologist, but was this done, like, did you use representative axial slices, for example, or was this a volumetric analysis to try to differentiate hypoxic from not hypoxic? And the second question, how did you actually decide what regions, because these tumors, as you know, are really big, like how did you decide what regions to actually sample post-resection? And it was just the other kind of observation, I guess, it's really quite striking how different, like I know these are small patient numbers, but how different the disease-specific survival was in these two different groups. Did you look at any other kind of tumor-specific or patient-specific factors that may contribute to that observation?
Yeah, thank you for those questions. So the first question I definitely find the hardest to answer because I haven't actually been directly involved with the analysis. However, I know that when analyzing the FASA uptake, so it's in comparison to the normal muscle, so they take the maximum uptake value from normal muscle and take one standard deviation, and then that's actually the value that's used to classify pixels in the tumor as hypoxic or not. And we actually did, so we have percentages of how hypoxic the tumor is. So we're actually looking at the total tumor volume, and we're able to determine what % of the tumor was hypoxic. Speaking about slices, though, I don't actually have an answer for that, but definitely something to look into. And then for sampling the tumor, so when we first started this project, we were trying to use the FASA scans to actually identify hypoxic and normoxic regions that we wanted to sample, and we started out by creating these 3D printed tumor models. However, there were some issues when we were trying to use these to actually mark regions of the tumor to sample, as we were seeing that they weren't exactly the same shape due to margins that were taken out during surgery or different tumor, the tumor either growing or shrinking due to treatment if that actually occurred. So what we ended up doing was just sampling different regions that the pathologist assistants deemed as viable, and we wanted to just sample different spatial regions of the tumor. And then, sorry, your last question
was just about the difference in disease-specific survival.
Oh, sorry, yes.
Like were some of the tumors bigger or smaller?
Yes, that's a great question. It's something that we're definitely starting to look into. All of the patients enrolled in this trial were high risk. They all had grade 2 or 3. We did look to see if there were any differences between that and didn't see any differences in outcome based on grade, at least in the univariate analysis. But definitely, I think looking at size could be a good avenue to go.
Thank you, and great work.
Thank you.
If there are no more questions from the floor,